Okay, good afternoon, everyone, and welcome to our next Burden EU webinar. Today we have the pleasure to get presentations from three representatives of the Italian Global Burden of Disease Initiative, which is coordinated by Dr. Lorenzo Monasta. And they will present a bit on the history, the activities, and the achievements of their initiative in trying to bridge the gap between national burden of disease assessments and work done through the Global Burden of Disease study. My name is Brecht de Vleeschouwer, and I'm an epidemiologist working at Cienzano and also the chair of the European Burden of Disease Network, which is supported through COST. And the aim of this network is to bring together people from across Europe and beyond who have an interest in burden of disease. We aim to come together, if that is possible, and to share experience and expertise so that we can integrate our knowledge and capacity in burden of disease assessment and also strengthen the skills that are already present. If you want to learn more about our activities, feel free to have a look at our website. At the moment, we have quite some activities going on related to the disease burden of COVID, and we are also planning the launch of a training school on burden of disease assessment. Of course, today we will be able to give the floor to some of the members of our network to present their activities. Before we start, some administrative notes. During the presentations, we will ask everyone to switch off their microphones and videos. If by mistake your microphone would be on, then I will switch this off from my end. After the presentations, there will be time for questions for some discussion. You can use the chat box in the WebEx system to ask your questions. You can also just unmute yourself and directly ask your question to the presenters. The presentations are being recorded, and soon the PDF versions of the slides will also become available through our website. Okay, so without further ado, let's have a look at today's schedule. So we will start with Dr. Lorenzo Monasta from the Institute for Maternal and Child Health in Italy, who will give an overview of the Italian Global Burden of Disease Initiative, focusing on the objectives, their experiences, and future perspectives. Then we will have two colleagues, Dr. Paolo Cortesi from University of Milano and Dr. Cristina Bossetti from the Mario Negri Institute for Pharmacoepidemiological and Economic Research, who will present some specific activities of the initiative, focusing on cardiovascular diseases and cancer. And I'm extremely happy to be able to have these presenters talking about their National Burden of Disease network, because their network is, to my knowledge, the best example of a very well developed, very active, very productive national network of burden of disease experts. The importance of burden of disease in Italy is also reflected within our European Burden of Disease network. So I just made this map to show the number of people from the different core EU countries represented within our network. And then you clearly see Italy popping up as the country with the highest number of representatives within our network. So again, showing the strong importance Italy is giving to burden of disease and to public health and epidemiology in general. So I want to thank everyone, not just the presenters, but also all the other Italian colleagues who are part of the network, who are contributing to the network. I want to thank them for their support, their activities, and their ongoing contributions. So without further ado, I want to now give the floor to Lorenzo, who will introduce us to the Italian GBD Initiative. Lorenzo.
Well, Brecht, thank you very much. Thank you to the COST Action. I'm really happy to be here with Cristina and Paolo to talk to you about the Italian experience in the GBD. Let me see if I can actually activate the presentation. I actually not able to do. Okay, do you see the presentation?
Yeah, perfect, full screen.
Okay,
perfect.
Thank you very much. Okay, so we started getting involved in the GBD during its actually before its first round of the GBD 2010. In the early stages of the GBD, when about 500 researchers had been involved in the first estimates, and in 2015 we actually started thinking about the possibility of having other GBD collaborators in Italy. So we contacted IHME and asked if there were any others, other collaborators in Italy. So they sent us a list. We discussed with IHME the possibility of creating a network with these GBD collaborators, because we thought it was better to actually not work alone, work together, because we believe research is an open process, should be collaborative. So in agreement with IHME, we contacted the other GBD collaborators. There were 12 at that time. And we had a first meeting in 2016. We actually believed in the GBD potential for several reasons. We thought it was the strongest and most complex effort ever made to collect, organize, and weight evidence. And in addition to this, in Italy, we always had quite a weakness in evidence-based planning and prevention. But we also, on the other side, have a wellness of data and collaborative research groups. So we wanted to take advantage of that. And the GBD is not only for, we believe, not only for planning, but also to verify hypotheses, identify weaknesses in the data. So it was also good in perspective for research purposes. Why not a burden of disease, a national burden of disease? Well, we've heard, we got to know other experiences of national burden of disease project, and we think they're amazing, really. We think the GBD is amazing too. We actually started this process, this network, as single researchers through a bottom-up approach without a formal mandate from the Ministry of Health or the National Health System. In addition, many of us have had experiences in burden of disease projects, and we know how complex it might be. So we decided it was good to follow the GBD and work to gain ownership over these estimates. In addition, we think the future should not see any conflict between GBD and national BOD experiences. We actually believe in the integration of these systems because we think that customizations, adaptations, and comparisons can actually enrich the whole process of burden of disease estimates generation. So we pulled the group together in 2016, and these are the objectives that were given to that we decided to put ahead: share experiences, to strengthen the exchange with IHME, spread results, because we believe that the use of data estimates and indicators is the best way to actually improve their quality. And then we wanted to consolidate the sharing of data and information that could be fed back to the system to generate increasingly better estimates. And then we were curious about going to the next step of having subnational estimates for Italy. Italy is quite heterogeneous in terms of regional differences from north to south, access, quality of access, of health systems, and even from the epidemiological point of view. So we wanted to actually have access to those estimates too. So we started collaborating with IHME, trying to see if there was a possibility for this. And actually estimates will be made public at regional level for GBD 2020, most probably in July. But the main aim was to, as I said before, gain ownership over GBD estimates. So from the 12 that we were in 2016, we are now more than 90 collaborators who joined the network. This means that there are other GBD collaborators that didn't join the system, the network yet. These 90 collaborators are from 25 research institutes. This is kind of an informal group. Then we have a formal agreement among institutions. So you see the ones in green are the ones that actually signed the formal agreement too. Now that we're 90 people, we divided ourselves in core groups. So we analyze and we we review the estimates in groups. Some of us are participating in more than one group. We have disease and injuries groups, as you can see, and then risk factors group. And then we have a group on health economics, SDIs, health access and quality index and inequalities. We are forming now a core group of health authorities, regional health authorities, who are very interested in using GBD estimates for planning at regional level. And then the National Institute of Health is also creating an internal group. So researchers will participate into the core groups, thematic core groups, but they also want to generate a group to work together as a group. Now we are working on several articles on neurological disorders. The ones listed here are being submitted, will be submitted soon or have been submitted already. So neurological disorders, redistribution of garbage codes, impact of air pollution, NCDs, etc. And then new ideas for analysis on GBD 2020 will be discussed. These are the ones mentioned here are on GBD 2019 estimates. So what's happening now? As I said, we are consolidating the group of regions. We have 5 regions now participating, and we are getting in contact with some more. We are setting up a website to increase the level of communication on national and regional level, both for policymakers and for the public. And I was mentioning before that we want to learn more from other countries' experiences. So we should also set up a network of countries that are doing more or less the same things that we are doing. Now that GBD 2020 estimates will come out, we want all the groups will mobilize to review the estimates and share ideas about new analysis on estimates. We are expecting for sure big discussions on subnational estimates, pros and cons and everything. But it's good. The more we discuss, the better the next estimates will be. So the idea is that through discussion and criticism also, we want to build more ownership and better estimates. I think the common objective of us all who are here is to have the best possible tools for evidence-based planning in general. These are the articles we've published till now. An article on Italy's health performance. And then, as I said, after my speech, you have Cristina Bosetti and Paolo Cortesi talking about their core groups and their publications, who we can see here, one on cardiovascular disease in Italy and one on the burden of cancer in Italy. So thank you very much.
Yeah, thanks to you, Lorenzo, and congratulations once again on this very nice initiative which keeps expanding. So every time we talk about the initiative, new groups get added and new activities get added to the list. So this is indeed very good to see.
We try to push it forward. Yeah.
Indeed. Yeah. Okay. I'm looking at the group because we have some time for some questions now. So as mentioned, feel free to use the chat to type in your question, or just directly unmute yourself and ask your question to Lorenzo. Maybe one thing that I was wondering about is if there are any activities within your group on COVID disease burden.
Yes, several thoughts. Well, several activities that are not specifically on the GBD, because the GBD estimates will come out in July, and we'll take into account also the COVID impact. But yes, we are also involved in this as a group. But still, it's a process. I mean, we are still waiting for data to consolidate more, and two ideas to consolidate more too. I mean, there has been a whole wealth of publications, but we're kind of holding back a little.
Yeah. But yeah, this will indeed, once the GBD 2020 will come out, will be a hot topic. And as mentioned by Zubair in the chat, Ireland, but all other European and other countries are indeed able to learn a lot from your initiative. One question that I see from Clara from Bulgaria is if the Italian network has any financing, because I can imagine that some of the activities can require some resources, or maybe not. So maybe if you can elaborate a bit on that.
Yes, this is interesting. We don't have any funding as a group. Each institute and institution and the university department that participates puts down what is needed for the activities that we need to carry out. So, of course, as a research institute, we have some funding on research that we dedicated to the global burden of disease initiatives. And when we organized the workshops in Rome, La Sapienza, Cristiana Baffati put some funds on this. Each one of us is putting some funding on specific initiatives, but we don't have a financing as a network yet.
Mm-hmm. Yeah, but to some extent that's indeed a bit reassuring, because it shows that even without structural funding, there's a lot you can do. So
yes, I mean, each one of us is getting a lot from the GBD in terms of research impact. And this attracts funding even from the ministry. Like, for example, we're a research institute, and even very basically from the impact factor that we get some funding back from the ministry, and this is of course getting to moving some funds to these activities and so on. So it's but very basic.
Yeah, no, thanks. We have two more questions. First from Katja. She's wondering if the subnational results are already used by the Ministry of Health or other institutes for planning. So this links to the knowledge translation element. So we, of course, want burden estimates to be used by the people who are in charge of policy and planning.
Well, as far as I know, we had several discussions with the MOH. I think they're interested in these estimates, and I think they take a look at them, but they haven't been officially using GBD estimates yet. Also because the subnational estimates, which are more relevant for planning in Italy, are still under embargo. But we have regions, as I was mentioning, regional health authorities who are really interesting, because now they're designing the regional prevention plans, and they're starting to use even the estimates that were embargoed to take a look and to design policies And for this reason, the group that we are creating now of regional authorities is crucial. I think it's going to be very important. Also because part of the planning in Italy, it's done at regional level and then transferred to the national level.
Yeah, indeed. Thanks. And then maybe a final question from Alibek. So he's saying that you mentioned support from IHME specialists, and he's wondering if IHME is charging for this support, or if you have local specialists who have been trained by IHME or at IHME to quantify the burden of disease in Italy.
Oh, okay. No, IHME doesn't charge. This is, I mean, what we obtain, like the extras that we obtain from IHME were justified by the impact that we had as a network. So I think this is a very important issue. We provided knowledge, expertise, data. We, in this regard, the MOH provided us with hospital admission data from a period of time from 2005 to 2018 now. We have causes of death data from the National Institute of Statistics, multiple causes of death also that we provided. And the impact of the network has allowed IHME to estimate, to generate estimates at subnational level for Italy, because they were also interested in all this wealth of knowledge and information. So no, yes, we got training from IHME. As you know, there is an online training that is free for all GBD collaborators. Plus, several of us went to the technical workshops that were held annually by IHME. But we got, I mean, we funded ourselves to go there. So we didn't get any, we didn't pay IHME for this, and we didn't get funding from IHME on this. So it's an open collaboration.
Okay, thanks a lot, Lorenzo. Then another question from Zubair. He's wondering which approach is more impactful to get started within a country. So would it be a regional authority mobilization approach or a national approach?
Well, it really depends on the situation locally. When you say regional, well, in Italy, we got the regional level involved, like the subnational, if this is what you mean, Zubair. Level involved quite late. But on the other side, what we found really simple to do is to contact all GBD collaborators that were already involved in the GBD action, and ask them to collaborate as a group, as a network. So there was no discussion initially about national or subnational. Most of the GBD collaborators involved at that time were on specific clinical issues. They were involved for specific clinical issue. Now this has changed quite a bit, but so the group was very heterogeneous, but they all were interested in GBD estimates as tools.
Mm-hmm. Okay, thanks. And I think the main message is you just get started and then it evolves. So the key thing is just to get it going and to take this first step, and then future will tell how it will evolve, but it will definitely evolve.
Unless you have a mandate from the national level, then, or from a regional level, then of course you take that road too. It might be easier if you have a mandate on that side.
Yeah, definitely. Okay, but thanks a lot again, Lorenzo, for the presentation and the nice discussion we've already had. I then suggest we move to the presentation of Dr. Paolo Cortesi, who will be zooming in a bit more on the work that is done by the cardiovascular disease collaborators within the Italian network.
Thank you, Brent. Can you see my screen?
Yeah, but not yet full screen, because you're about to press the button, I see.
Yeah.
Okay, perfect.
Yeah, thank you for inviting me. After Lorenzo, I would like to present the experience of a collaborators group that we have created to working on cardiovascular disease and show how we started, what we have done, and where we are now about the collaboration also with the IHME. And we started with the group essentially in March 2019. After, in that time period, the IHME proposed a collaborator lead publication, so a proposal for article. And so Lorenzo provide and invited for all of us to maybe propose some topic and some article using the GBD data. And what was for us that the first step is creating some group of people that are interested in some topic in order to follow the interest of these people and creating some publication on that topic. And so we created the first group, and one of this group was the cardiovascular disease collaborators group. And how we created the people that how we select the people that are part of this group. Basically, we ask for application within the member of the GBD Italian group. We ask the people if they're interested and if they have experience in cardiovascular disease, if they want to become part of this group, with basically the aim of starting to use the GBD data for a publication. So the first step was, I think, an aim that is more concrete than just review data. Is we want to use this data, so we ask people if they want to be part to use this data for a publication and for discuss these results in a publication to make some maybe issue available for decision maker to make some change in their policy. And basically, we accept all people that apply for being part of the group, but we also select a leading group within all these members. There are 5 people. They are selected based on the experience, of course, in the cardiovascular disease studies, in the project management, but also on the motivation that the people have to lead this work and this article, and also the possibility to interact with the member of the leading group in an efficient way in order to make it more easy and fast. And of course, within this group, we select also a coordinator that at the time was me, in order to make the process more fast and try to get the aim of having a first draft of our publication by the end of the year. And so in April, May 2019, we start reviewing the GBD papers on cardiovascular disease and the study on the Italian cardiovascular disease burden in order to identify what is missing related to the evidence available in the literature and what we can provide as useful information with our work. So what we already know about what we found with our review is that, of course, there are a lot of information about cardiovascular disease in Italy because there was in the past a lot of initiative, but there is no a global assessment of all the cardiovascular disease, and there are a lot of information that do not include all cardiovascular disease, or they report just some information, and so this is something that with the data of global burden of disease can be done, and so we start to define our aim, that is, of course, using the GBD estimate to fill the gap of a global estimates of all cardiovascular disease aspect in terms of prevalence, mortality, and dailies from 1990 to 2017, and also because what could be also interesting for decision makers is comparing our results with our other European countries, because it's something that is really useful and something that we can do with GBD estimate that have a standardized approach that make this comparison possible for us. Of course, the aim was proposed by the leading group, but was provided to all members for a revision and a validation in order to have an agreement of what should be the aim of this first project for our group. And so we move to define the structure and define the data that we want to include in the paper. We, of course, review the GBD papers to understand better the structure and how they have used the data related to cardiovascular disease, to have some example to define our project and our paper. And so we set the structure and we define the data. This process was done by the leading group. And of course, when we have decided the structure and which type of data we want to include, we send to all members of the group in order to have a revision and approval by all group members. This is important to work together and to have a shared aim for the project. And when we draft the manuscript, of course, we start to select the target journal. But what is more important is also the definition of the task and definition of a member within the leading group that is in charge of each task. Of course, all the members can work on each task, but we need to have some person that is reference for that activity. One was the data extraction and review. The other is the creation of figure and tables. The other is draft the method section. One is draft of results section, and finally the draft of the introduction and the discussion. When we have done the full paper and the first draft, we share with all members for a first revision. We collect all the comments that we have. We make the change that we consider correct and can improve our first draft, and we share again for a final revision and approval by the Cardiovascular Disease Italian group. After this step, we share the paper with the IHME leading group of cardiovascular disease project for a final revision and a validation also for the data included and the method description, and to have a final paper to submit to the journal. So this is what we have done as a first task as a cardiovascular disease group. And as Lorenzo has already shown, we are able to publish in the European Journal of Preventive Cardiology the paper to show the change in the burden in Italy from 1990 to 2017. And also we provide, as I told you, some comparison with other European countries. But I think what is really useful in making a paper and using the data of GBD in a specific way for our country is that this gave us the possibility to review more critically and in more details all the estimation done and the difference that there was between the data provided by GBD and the estimation that are available for Italy made by other projects or provided by national institution. And this helped us to increase the collaboration with IHME about the methods used and the discrepancy that we have observed within some data. And so we moved to the next step, that is in January 2020, that was a technical workshop to review the estimate of GBD 2019, and using the group, the cardiovascular disease group, and the other group that was established for the creation of first paper, we were able to divide the task and to review the data in a more efficient way, because each group was focused on their related data and estimation. And so we have a meeting. Before the meeting, each member of the cardiovascular disease group review the data by themselves in order to coming at a workshop of some idea of what is working and what is not working. And we have a discussion about the preliminary results and the evaluation with all the other groups. And we create a report for the IHME with all the issues that we have raised in the revision of the estimation, comparing of what we have in Italy made by the national institution and by other projects. In particularly, what we have reviewed was also the regional estimation. And I think this is a really important step, because national estimates are useful, but from the Italian point of view, having regional estimates can be really more useful and can be really more applicable due to the really big difference that we have between region. And so we work on the estimation of cardiovascular disease mortality, and we compare the data from 2010 in 2010 and 2019 with what was provided by the National Official Statistical and by the WHO. And we make this comparison for all the cardiovascular disease and for two subcategories, the stroke and ischemic heart disease. About the incidence, we don't have official data in the period considered. So we use studies on cardiovascular disease incidence, and we also use the database of one Italian region in order to make the first comparison and to understand if the data provided by GBD can be reliable and used for be sharing to all policy maker in Italy. And of course, what we have done is sharing also the results for stroke with the neurological group, because as you know better than me, there is some overlap between groups, and it's really helpful to share thoughts about one problem with people that have maybe a different vision and a different point of view when they assess the data. And at the end of this workshop and this work, we have provided a final report when we report the discrepancy between the regional Italian statistics and the GBD estimate in order to have a discussion with the AIHME of what could be improved and what could be on what we could plan for having a better estimation. And we still have an open discussion. We have some meeting. We have presented our concern. They have explained why there could be this difference. And I think this is a tough work and is still ongoing, but it's the most important aspect if we work in a specific group within a country like us in the cardiovascular disease group, because we want to have something that could be really reliable in order to present also the GBD estimation and something that can be used for planning the prevention and the public health intervention at a regional level in Italy. And I would like also to thank all the cardiovascular disease collaborators that I have reported here.
Yeah, perfect. Thanks, Paolo, for this very nice overview, and also congratulations once again on all the work and efforts that you and your colleagues have been doing. So when looking at the chat, because again, we have some time for questions, I see a question that Joao put in before you started your talk, but I think it can also be relevant here. So he's wondering if there has been a collaboration or reaction of the Italian NHS or Public Health Institute to the initiative and the specific activities. So is there any, how is the interaction at the moment within the Institute? Is there any specific national department on population health monitoring and planning that could connect to the work that is being done within the initiative?
I think Lorenzo is the right person to reply to this because he's in charge. I know that we have really increased the collaboration with the National Institute, showing this work. I think what is important is showing that we are using the data, we are providing information for the discussion, and this probably make them more aware of this work and the possibility that we have with this data.
Well, can I? The National Institute of Health actually signed a memorandum of understanding recently with IHME directly. They're part of the network, and they're part of also the formal framework that I was talking about. And recently, the number of GBD collaborators in their part of the National Institute of Health has increased enormously. We had a meeting in when was that? In February, I think, in 2020. Then, of course, everybody was busy with COVID issues. But we had a workshop recently, a couple of weeks ago again, and they're willing to get more and more involved in this. And as I said, the number of GBD collaborators, the registered collaborators within the Institute increased enormously. Regarding the Ministry of Health, as I said, we had several meetings and they are certainly interested. Formally they agreed to this process, and through this agreement they are providing us with data that otherwise would not be in our possibility. So they're looking at what we're doing, but like stepping back a little bit. But I think they're interested in these results too. Yeah.
Okay, no, that's indeed very nice to hear that there's increasing collaboration with the official health institute. So this will only strengthen all the work that everyone is doing, of course. And I see a question from Zubair, who actually a question that follows up on this discussion. He's wondering about the level of discrepancy between the official national statistics and your estimates for cardiovascular disease mortality.
As I told you, we found some discrepancy. I think this was really helpful because, as Lorenzo showed, he is now working on how they are using garbage code, because that was one of the main issues related to the discrepancy that we have found. So, of course, I think that assessing at a global level as the GBD done, it could be really useful for having something that can be comparable within countries, but within a single country at a regional level, we have to review and discuss more deeply how to manage some discrepancy, because I think it's really related to the methods used, and we can improve them in order to make them more reliable.
May I add on this?
Sure.
Just a brief note. For this reason, we're writing this paper on garbage code redistribution. Garbage codes are ill-defined causes of death, like the causes that are either too generic, so cannot identify underlying causes of death. Because we realized that, as Paolo was saying, some of these discrepancies between official data and GBD estimates were the fact that in Italy we have 25% of ill-defined causes in causes of death, and Italy it's one of the best countries in Western Europe. So the best performing country has still, like, I think it's Sweden, or it depends how you consider if you age standardized or not, but it's UK, Sweden, around 20%. So 20% of causes of death are ill-defined and need to be redistributed because they don't identify underlying causes of death. And this, of course, when this redistribution happens, and the redistribution is based on literature evidence, scientific evidence, and also multiple causes of death can actually help a lot in identify the true underlying cause of death. When this redistribution happens, of course, the number change a lot. We want to present these results about Italy with comparison with other Western European countries to understand why this can happen, like why official data in some cases can be different from GBD estimates.
Yeah, thanks a lot. And this is indeed one of the also one of the important side effects, so to say, of a national burden of disease study, that you are forced to look at the quality of available data, that you are also forced to better understand all these methodological aspects. So in the end, we can only benefit everyone from doing such national burden of disease studies. In the chat, I've also put a link to a recent article from the group in Germany, who has also looked into garbage code redistributions within their country. We have a few more questions, but I would like to keep the question of Ali back for the end, because it talks about future perspectives. And for the interest of time, I would maybe like to invite Cristina now to share her presentation with us. Thanks again, Lorenzo and Paolo.
Okay, good afternoon. I will share my screen. Okay. Okay, can you see my screen?
Yeah, perfect. Thank you.
Okay, thank you to Brett for inviting me to this webinar to share with you my experience with the Italian GBD Initiative. I will first introduce myself. I'm Cristina Bosetti and I work at the Mario Negri Institute in Milan as an epidemiologist, and particularly work on cancer epidemiology. And I've been since long working on the patterns and trends of cancer at an Italian and European level. For my interest, at the beginning of 2018, I joined the GBD collaboration. And soon after, I was contacted by Lorenzo Monasta, who, as you know, is the coordinator of the Italian GBD Initiative. And in the same period, I participated to the first workshop in Rome, in which I started to understand the GBD world, the idea, the activities, and particularly the activities of the Italian GBD. My participation really started 1 year after, at the beginning of 2019, when Lorenzo, with also Paolo and other collaborators, organized various working groups focused on to better understand the burden, the Italian burden of a series of diseases, including cardiovascular, brain, renal, and cancer. At that moment, it was created the working group on cancer, in which I was really interested, and I took the leadership of this small group, in which, besides me, there was Lorenzo Monasta and his colleague Eugenio Traini, and other colleagues from the Mario Negri, from ISPRO Florence, and from the CPO Piemonte in Turin, which are all people researchers working on cancer, particularly on cancer epidemiology. And the first aim of the working group of cancer was to prepare a draft publication in order to give a better idea of the burden of cancer in Italy using data from 2017. And before starting this publication, we choose the type of, because within the GBD there are different types of collaborator-led GBD papers with different levels of involvement of the GBD team in Washington. And we choose the third type, in which the collaborator can choose the design of the paper, write the paper, extract the data, and create tables and figures, serve as a corresponding author. And in this type of GBD papers, the role of the GBD teams is quite limited. They just give some help for the editing to circulate the draft among the other GBD collaborators and some other but in this type of collaborator-led GBD paper, the collaborator is quite independent in the production of the paper. And if you want to need more about this, you can go on the GBD training that Lorenzo already mentioned. That is very useful to understand the data, the resources, the tools, and everything about the GBD. And there is also an interesting GBD webinar on the types of collaborator-led GBD papers. So we start organizing the idea of the paper that was to give a complete idea of the burden of disease, of cancer disease in Italy. And one of the big effort was to the data extraction and data elaboration, which was done by Eugenio Traini, a colleague of Lorenzo. And from the GBD database, he extracted not only data on incidence and death, but also number of years of living with disability, numbers of years of life lost, and the dailies. So we extracted numbers, crude rates, and age standardized rates. And this was done for 30 cancer sites and for all neoplasm overall. And data were covered the period between 1990 and 2017. So the idea was not only the originality of the paper was to show data not only on mortality and incidence, since there are already many papers on this matrix, but also other types of matrix which contribute to give a better idea of the burden of cancer. And for data extraction was very useful, this tool, the GBD results tool on the GBD website, in which it's possible to select the matrix in which you are interested, so number of cases, number of deaths, dailies, and so on, the country, the period of interest, and it's possible to extract all the data in an Excel file in order to use this data for producing tables and figures. And after the, so we collaborate with Eugenio, Lorenzo, and the other collaborators in preparing the manuscript and in revising it. An important step was then to send the draft manuscript to the GBD IHME collaborators for the revision and to circulate the manuscript among other GBD cancer team. This was an important step because they gave us a very useful revision, comments, and this was for us very important, although it took quite a while because the teams, the GBD teams are very busy for many other activities. But I think this step is very important. Also, it is a guarantee of the quality of the paper and that it follows the idea of the international GBD. The paper was then published on scientific reports, and as you can see, besides the Italian GBD cancer collaborators, there were also the collaborators from the IHME who provided us their revision. And you can also notice that the paper was published as an open paper manuscript, and this is because within the idea of the GBD is to make all the publication free and available to as much as a researcher as possible. And in this regard, they pay for the bill to make our publication free and open. And after the manuscript, the Italian GBD Cancer Group was also involved in the activity that also Paolo mentioned, because in the beginning of 2020, there was a workshop in Rome in which we were involved in the evaluation of national and particularly regional GBD 2019 estimates. At the time of this workshop, the cancer group increased with inclusion of other Italian researchers involved in cancer, particularly cancer epidemiology. And we, for this workshop, we made some comparison of the Italian GBD cancer estimates with the national and regional ones. In particular, just to give you a brief idea, we compared the GBD estimates with those provided by ISTAT, which is the Italian Institute of Statistics, and which provide mortality data based on vital registration date. And as you can see, we found some discrepancy. In particular, we noticed that GBD tends to overestimate the total number of neoplasma as compared to ISTAT by about 8%. And this overestimation is particularly more sensible for some cancer, including the most common cancers, stomach, colorectal, lung, and breast. But we also noticed that the number of other malignant neoplasm and other neoplasm was quite reduced, and I will show you in a moment the reason. We also make some comparison of incidence data comparing GBD data with those provided by the AIRTUM, which is the national registry, is the network of the Italian cancer registries. And also for incidence, we notice some discrepancy with an overestimation of the number of new cancer cases for various common cancers. In particular, we noted huge differences in the estimates of all new cancers. The number was about 370,000 based on the AIRTUM data, and was over 5 million, 5 million on the basis of GBD data. So we have a lot of discussion within the cancer GBD working group, and also with the other collaborators involved in other working groups. And then we had a nice and important meeting with the GBD cancer team that Lorenzo organized in June. And during this telephone conference, we had the occasion to better understand the source of data, use the models. And we understood first, we clarified that the huge difference we found in incidence was due to the changes in input sources in 2019 as compared to the previous year. So they use also outpatients data for these estimates. Moreover, they included also the number of non-malignant cancer. This can be a quite questionable choice, but they decided to consider also benign tumors. And then we better understand the problem that most of the measured discrepancy was due to the fact that they do a redistribution of all the unspecified cancer codes, the so-called garbage codes, into specific cancer sites. And this is done not only for the category of all the neoplasm without the specification of cancer sites, but it's also done for unspecified liver cancer. As you can see in this slide, for example, in Italy, there were 3,500 unspecified liver cancers. And after all their models, these cancers were allocated to specific cancer sites, because we know that often unspecified liver cancer are not primary liver cancer, but are metastatic cancer, are secondary neoplasm. And at the end of their process, there were only 378 primary liver cancer, while all the remaining unspecified liver cancer were relocated. And this produced an increase in the number of cancer. This is done through a very quite complex and sophisticated model, which is not really easy to understand and to go into this model of estimation, although we understood that the GBD team is doing a big effort in trying to get most of the data sources and to get the best modeling in order to have very reliable estimates. It remains the problem that the differences, the discrepancy with national data is a problem, and we will have still to discuss this problem also when very soon when the regional estimates will be published by the GBD. I thank you for your attention.
Yeah, thanks a lot, Christina. And again, a nice example of how working on burden of disease can help to better understand the national estimates and vice versa. So again, some very nice examples there. So thanks a lot. So I'm looking at the chat just to see if there are already any specific questions for Christina on the cancer burden. I also see that we're already at the end of our 1 hour time slot. So maybe to conclude the session, I want to ask you or your colleagues if you can say a few words on the future prospects or the future plans of the Italian Global Burden of Disease Initiative. So do you have any concrete plans to expand towards other domains, other groups, other activities? And I see Lorenzo is already smiling, so
yeah,
maybe...
Lorenzo probably knows better than me. I think that now that there will be the release of the regional estimates, this could be the occasion maybe to plan some other activities, maybe a new publication focus on regional estimates. Now it's quite problematic because probably we cannot do for all the neoplasma, but maybe choose a specific neoplasma of interest. But I think it would be a good occasion to prepare a new publication and to share these regional estimates.
Yeah, indeed. Lorenzo?
Well, yeah, thank you, Brecht. We certainly need to improve our communication, and this is for this reason the website will be crucial. We certainly will have a lot of work to do when regional estimates will come out, as Christina was saying, because there will be a lot of differences that we will need to understand and explain and fix either way or another. So it's going to be tough, and then we need to keep on pushing on regional health authorities to get involved, because we think this tool as a free tool is very important for their activities. So yeah, lots of things. I also see a question if we already undertook steps to reduce ill-defined codes of death. No, not yet, but we understand where most of the problem is, and we saw there is an heterogeneity which allows us to think an heterogeneity among countries and among regions, and through this heterogeneity we understand that a lot of things can be done. You have to consider that in Italy we still rely on paper records on causes of death. So the doctor actually writes down on an open space the cause of death, and this goes to the National Institute of Statistics. That they have to be coding, and they do it's a huge effort to actually make this coding right. So, for example, for this, we will push towards the fact of having an electronic way of recording causes of death with checks and filters, and this could reduce. But also the discussion among countries can actually help a lot understand why in certain countries certain codes are certain garbage codes almost don't exist or have very small percentages if compared to others. Even countries that don't perform well for certain diseases have very nice codes than others that perform well. So I think a discussion needs to be done to fix all of these things.
Yeah, indeed. So this is a very important topic. It also has a very big impact on the final results of any burden study. So maybe it could be an idea to dedicate one of our future webinars to this issue of garbage coding and to share some experiences from across the world. So this will be very valuable and interesting. Okay. So with that, I want to thank you all once again for your contributions and your attendance. In the meantime, we had to put the PowerPoint or the PDF versions of the presentations online, and very soon you will also be able to access the recording via our website and YouTube. In terms of future prospects, I'm happy to announce that our next webinar will take place on the 21st of May on a Friday, and will focus again on COVID disease burden. So we'll have some initial updates on DALI estimates for COVID, and we will also be able to talk a bit more about the possible impact and uncertainties with regards to long COVID, so the post-COVID conditions, and how that figures in burden assessments. So please keep an eye on our website and on your mailboxes if you're a member of the network. And yeah, thanks again for being here for the presentations and the interaction. And I wish you all a very nice afternoon or evening or day. And we look forward to seeing you again in one of our next events. Yeah.
Thank you, Brett.
Thank you.
Thank you.
Thank you. Thank you. Bye-bye.
Bye.
Bye-bye.